respiratory pathology, pulmonary hypertension, as well as physical exam findings for selective lung diseases. All right, so up next is pulmonary hypertension. First and foremost, what are we going to see? We're going to hear, actually, a loud P2. So loud P2 denotes pulmonary hypertension. So keep that in the back of your mind. If you ever see loud P2, that means they're mainly talking about pulmonary hypertension, probably, okay? And the reason behind that is, once again, pulmonary hypertension means that it's harder to get through that pulmonic valve, right? So if we can't get through that pulmonic valve as much, we have to increase the pressures in the right ventricle. And to increase the pressures in the right ventricle, we're going to shoot out all that blood, and it leads to a louder closing of that pulmonic valve, okay? So that's all that occurs. The main symptoms we're going to see is exertional dyspnea, okay? And they love to differentiate it between groups, but the only one that really matters is group 1, okay? And this is pulmonary arterial hypertension, okay? So essentially, the pulmonary arteries are going to be relatively harder, or vasoconstriction, they could be harder to get blood through, okay? So they're not as compliant. Now, it's often idiopathic, we don't know why, and it's highly associated with females. Okay, so that's something that they love to ask about, is the female association with pulmonary hypertension. Now, it's also associated with an inactivating mutation with the BMPR2 gene, okay? And what that BMPR2 gene is associated with is that it normally inhibits vascular smooth muscle proliferation. But if we have a mutation of BMPR2 gene, then that means that we can't inhibit vascular smooth muscle proliferation, so we have an overall increase in vascular smooth muscle, and we get a very, very tight squeeze for our pulmonary artery. Okay, so it becomes essentially vasoconstricted with all the vascular smooth muscle located there. Okay, so pulmonary vasculature endothelial dysfunction results in the increase in vasoconstrictors. So you're going to see a decrease in prostacyclin, which is a vasodilator, and you're seeing an increase in thromboxane 2, a decrease in nitric oxide because it's a vasodilator, right? So keep in mind, the vasodilators like prostacyclins and nitric oxide decrease in pulmonary hypertension, and the vasoconstrictors like thromboxane, they're going to increase in pulmonary hypertension. Okay, so it's all about vasoconstriction. Okay. Lastly, the patient is going to present with plexiform lesions, which is just like multiple lumens within the pulmonary arterial. It's not as high yield, but it's just something that you can kind of take into account when talking about pulmonary hypertension. Lastly, how are we going to treat this? Usually patients are given bosentan. Okay, so bosentan is used to treat, and they antagonize the endothelin receptors. So endothelin receptors are going to be blocked by bosentan, which leads to an overall vasodilation, because normally endothelin is a vasoconstrictor. All right. So overall, that's something that they really want you to know about pulmonary hypertension. There's other causes of pulmonary hypertension, like left heart disease, lung diseases, chronic recurrent PEs, and other things. But once again, the group 1, pulmonary arterial hypertension, it's due to the smooth muscle proliferation. So be aware with that one. Next is physical exam findings in selective lung diseases. I can't tell you how important this is. This page is very, very important. This chart is very, very important. Be keen on understanding everything that's going on with the physical exam findings. It's going to be helpful for not only your NAMELD exam, as well as your step 1 and boards exams. All right, so first, what I want you to differentiate between all of them is that with breath sounds, everything is decreased, okay? Everything is decreased with breath sounds, pleural effusion, atelectasis, pneumothorax, but for consolidation, like lobar pneumonia or pulmonary edema, it's the only one that has an increase in breath sounds, okay? And that's known as bronchial breath sounds. So if you see bronchial breath sounds, you get rid of everything except for consolidation, okay? Very easy. Next is percussion. Everything has dull percussion except for 2 things. Pneumothorax has hyperresonant, and that's going to be the highest yield thing. If you see hyperresonant, the number 1 thing on your differential should be pneumothorax for percussion. But you can also have hyperresonance in emphysema patients as well, okay? So keep that in the back of your mind, but majority of the time, the pneumothorax is going to have hyperresonant percussion. Next is fremitus. Fremitus is going to be decreased in all of them except for an increase in consolidation, okay? So everything's going to be increased except for consolidation. Consolidation has an increase in fremitus. Sorry, I misspoke. Everything for fremitus is going to be decreased except for consolidation. Consolidation has an increase in fremitus, all right? Those are so important to understand and memorize and know, so keep that in the back of your mind, and you should be good.